My name is Michael Kaminski. I'm a group leader at the Max Delbrück Center for Molecular Medicine in Berlin, Germany, and I'm also working as a clinician at the University Hospital Charité here in Berlin. The main goal of our lab is to develop and apply technologies that allow us to better understand, treat, and diagnose diseases, with a special focus on the kidney. So today, I'd like to share a couple of examples on how we use CRISPR-Cas systems to detect biomarkers relevant for kidney disease and health. As you might know, there are different point-of-care diagnostics which are currently used in clinical routine. Specimens can include saliva, urine, or blood. And lateral flow tests typically sense proteins present in these samples. These are widely used for the detection, as you may remember from the SARS-CoV-2 pandemic, and they are fast and robust, but they really require antibodies which are specific. Especially in urine, dipsticks indicating metabolites are widely used and are a very important part of the diagnostic workflow, especially for nephrology. So while these technologies are perfectly suited for point-of-care implementation, they lack sensitivity, specificity, and easy programmability as compared to nucleic acid-based diagnostics. Therefore, all-in-one machines which combine sample processing, amplification, and the detection are being used in clinical routines, which you see here in the slide below. These technologies are mostly based on PCR and comparable to conventional PCR testing in terms of their sensitivity and specificity, but they are much faster and easier to handle. However, they still require complex and costly machinery, and this really limits their use in resource-limited settings. So we think there's much need for technologies that allow in a similar way as our paper-based antigen tests indicated above. And to this end, we develop and apply CRISPR-Cas systems. There are multiple approaches to use CRISPR-Cas systems for diagnostics. Here I briefly show two prominent examples, referred to as Sherlock and Detector, from Feng Zhang's and Jennifer Doudna's labs. So in the first step, DNA or RNA is preamplified to reach the limit of detection for the Cas enzymes. To this end, most protocols either use PCR or isothermal amplification techniques, as shown here, such as recombinase polymerase amplification. This step is crucial for many nucleic acid targets, which typically are present at low concentrations, for example, in the attomolar range. Sherlock typically involved RNA detecting Cas enzyme, such as Cas13, but this requires T7 transcription of the DNA products from the RPA reaction into RNA. Once the enzyme detects a target complementary to the guide RNA, it triggers so-called collateral cleavage activity, and it cuts adjacent RNA molecules. This we can take advantage of by adding these RNA reporter molecules into the reaction carrying a fluorophore and a quencher, for example, and once they are cut, they are spatially separated, and you can read the signal on a plate reader, for example. Another great advantage of these CRISPR diagnostics is their flexibility in terms of readout technologies, which you can see here to the right. So I already mentioned that fluorescent-based technologies are commonly used, but it's also possible to visualize the cleavage of these reporter molecules on paper, on lateral flow strips. Groups have also worked on visualizing or interpreting the results using electronics, and in recent publications, we've also seen that these materials can be incorporated into face masks, allowing, for example, for patients that are infected with SARS-CoV-2 to indicate the presence of the virus in the material. We applied CRISPR diagnostics to the field of transplantation medicine. We think this could be an area that can especially profit from point-of-care diagnostic, since it requires frequent and continuous testing for infection and organ rejection. Why is this the case? So patients undergoing transplantation need to take immunosuppressive drugs which prevent the risk of organ rejection. However, they come at a cost, which is mainly the risk of developing infections. And in the clinic, this is really a challenge to differentiate between both when the function of the transplanted organ declines. So we developed a CRISPR-based assay to sense two of the most common so-called opportunistic viruses, which is cytomegalovirus and BK virus. We also developed an assay to sense CXCL9 mRNA, which is a marker known to be upregulated during acute cellular rejection. Our assay correctly discriminated all BKV positive samples from the negatives. Importantly, this worked on both urine and plasma samples, and it also worked using a crude extraction protocol known as the Hudson protocol established by Cameron Meerwald. For cytomegalovirus, we achieved a 80% sensitivity when using Hudson and 100% sensitivity when using column-based extractions. Further, the assay detecting CXCL9 mRNA achieved around 93% sensitivity and 76% sensitivity. All of this was compared to the clinical gold standard, which is a biopsy. Here are three examples on how we monitor transplant patients using these tests. So the patient to the left, he suffered from BKV nephropathy. We could measure high BK virus titers by qPCR in his blood. After changing the immunosuppressive treatment, the patient managed to clear the virus from the blood. Accordingly, we could detect BK virus in urine by CRISPR diagnostics early on, as indicated here by the positive test band, but not at later time points. To enable an easy readout and interpretation of the result, we established a smartphone app that would allow to interpret the intensities of these test bands. The two patients on the right experienced organ rejection. The one here in the middle was diagnosed with acute cellular rejection in a biopsy. PCR revealed high levels of CXCL9 mRNA in the urine, this known marker of cellular rejection. After intensifying his immunosuppression, the rejection was successfully controlled, with CXCL9 levels going back to normal after 3 months. CRISPR Diagnostics, as shown below, showed the same pattern, allowing to monitor the treatment response. The patient to the right also presented with acute cellular rejection, but failed to respond to the treatment. This resulted in chronic rejection after 10 months. Using CRISPR Diagnostics, we could detect CXCL9 mRNA at these late time points indicative of chronic rejection. So we really think that point-of-care diagnostics are not only useful in emergency settings, but also when doing repetitive monitoring of biomarkers. One main drawback of current CRISPR diagnostics is the need for pre-amplification. So that's why we're in a collaborative effort with nano-engineers from Molly Stevens' group explored the use of nanozymes as signal amplifiers. Nanozymes are gold core platinum shell particles with enzyme-like properties. In our assay, they catalyze oxidation of tetramethylbenzidine, visible by a color change. And now coupling these nanozymes to streptavidin, it allowed to bind biotin-carrying RNA reporter molecules. In a negative sample, as shown above, without the target analyte being present, these reporter molecules stay intact. Nanozymes can bind and the color change is visible. However, in a sample containing the target analyte, Cas13 cuts reporter molecules such that the nanozymes can no longer bind and no color change is observable. So the advantage of this assay included a more robust detection of analytes in the low picomolar and high femtomolar range, while it didn't necessarily increase the absolute LOD. However, it also allowed for visual outputs and better quantitation of the analytes. We applied CRISPR-Zyme to sense different RNA species in biological and clinical samples. We detected, for example, microRNA 143 in iPS-derived cardiomyocytes, allowing to track successful differentiation of these cells in the lab. In a patient cohort that presented to the emergency room with chest pain, we identified upregulation of long non-coding RNA LIPCAR in patients with myocardial infarction, as indicated by the troponin T levels. And finally, we assessed if CRISPR-Zyme was compatible with RPA preamplification for the sensing of very low abundant RNA species. By designing RPA primers, which are divergent, and placing the guide on the backsplicing junction, we were able to detect circular RNA species, such as circular aurora kinase A shown here. This allowed to differentiate prostate adenocarcinoma from neurocrine adenocarcinoma. And these two entities strongly differ in their clinical outcome. In our current work, we now extend CRISPR diagnostics for sensing of genetic risk factors relevant to disease. To this end, we optimize sensing of SNPs, small deletions, and insertions. By screening a larger set of guide RNAs, we identify those that have a high discriminative power and that enable discrimination between the on and the off target, which just differ by one or a couple of base pairs. In addition, we test for guide RNAs that not only allow to discriminate between on and off, but also detects the mixture of both. And this we can achieve by introducing various synthetic mismatches into the guide RNA. These mismatches are neither complementary to the on nor to the off target. Ultimately, this allows, with a single guide RNA, to discriminate between homozygous carriers, visualized here in orange, heterozygous carriers in yellow, and the wild-type alleles visualized in blue. To discriminate between multiple SNPs or deletions in one reaction, we took advantage of orthogonal cleavage properties of these different Cas enzymes. So by testing LWA Cas13A, PSM Cas13B, and LBA Cas12A, together with different orthogonal cleavage reporters, we identified some combinations that allowed to perform all three Cas reactions in one pot. By assigning a unique fluorescence pattern to each genotype, we could differentiate between patients that had a high risk of disease, a medium risk, or no risk of disease. Importantly, we validated our findings in a cohort of over 100 patients with an accuracy of 97% as compared to gold standard Sanger sequencing. And we have to have in mind that the conventional PCR followed by Sanger sequencing is pretty costly in clinical practice and can take several days to return results. Our CRISPR-based sensing of SNPs could be completed below 2 hours, and the readout is much easier. So in summary, we've shown that CRISPR-based diagnostics enable sensitive and specific sensing of kidney disease biomarkers, infectious agents, mRNAs indicative of disease, but also genetic variants. Easy accessibility of the urine and paper-based readout technology really enables point-of-care diagnosis for kidney diseases. CRISPR-Zyme allows for signal amplification and versatile but quantitative readouts. However, even with these efforts, we still need preamplification for lowly abundant targets in the attomolar range. And finally, multiplex CRISPR diagnostics enable point-of-care genotyping of genetic risk factors. So what are we currently working on? We aim to combine CRISPR diagnostic with microfluidics to allow for parallel multiplexing. But we also aim to perform pooled multiplexing and, importantly, visualize these on a piece of paper. And finally, we use deep learning-based tools to design guide RNAs, but also analyze lateral flow results. So I'd like to thank all the people involved, the institutions supporting us, and the funding agencies. I'm especially grateful for our talented PhD and MD students in the lab working on CRISPR diagnostics, Robert Greensmith, Qiao Meng, and Alexander Schubert. I also thank all collaborators from Charité and MDC, Jim Collins at MIT, where this work all started during my postdoc, and the clinical collaborators from Boston, Leonardo Riella. I also thank Molly Stevens and her group for the collaborative effort on nanozymes, and I thank you for your attention. Thank you.